I'm Dale Bond. I'm an associate professor of psychiatry and human behavior, and I work at the Weight Control and Diabetes Research Center, which is affiliated with both the Miriam Hospital and Brown Albert Medical School. I've always been interested in migraine because I suffered from migraines as a kid, and that were often frequent and quite severe. And I still experience them to this day, but not as frequent or severe. And I've always just kind of been fascinated by the complexity of the disease and how little we know at this point, even now. I've always kind of been interested in the behaviors that contribute to migraine, and so we developed a video to try to help patients better self-manage their migraines. And so that involved taking medications more appropriately and regularly, also in terms of stress management, relaxation techniques, as well as physical activity. And the focus here is obesity and weight control. And if we look across the different studies, what we'll find is that this association between obesity and migraine tends to be stronger in reproductive age individuals as well as women. Another important thing we are starting to see is that it's not only in terms of just kind of general obesity, but it might also have something to do with the location of where a person holds their weight. For example, abdominal obesity being associated with migraine. And it's not just the overall obesity, but also the degree to which somebody is obese. And so individuals, for example, with a body mass index over 40, which we would call severe obesity, they're at much higher risk of having migraine compared to someone who has more mild obesity. And so we just completed data collection on a NIH-funded study that actually tested the effects of behavioral weight loss compared to a migraine education control condition. And so in this particular study, women, reproductive age women, so 18 to 50 years old with a BMI of at least 25, up to severe obesity. So 25 BMI would be considered overweight, and then all the way up to a BMI of 40, which would be considered severe obesity. And so in this study, women were randomized to 16 weeks of group intervention of either behavioral weight loss, in which we taught them different behavioral strategies to try to increase their physical activity and also change their diet. However, we did not talk about migraine. And the control condition, which they received 16 weeks of migraine education, but we didn't talk about obesity or weight loss. We see that individuals sometimes use eating as a pain coping mechanism, and that palatable foods in particular can serve to suppress pain. And also, it's kind of interesting to think about because we usually think of migraine as involving nausea and vomiting and anorexia. So like, why would anybody want to eat? But what they're showing, again, by using smartphones and more real-time methods is there's extreme variability in experiencing those symptoms. Some patients don't experience that at all. Some patients only experience it during a minority of their, during a small number of their attacks. And so also we see fluctuations in hormones that influence appetite during an attack. And so when we see these large, up and down type cycles, is that actually can contribute to overeating. But no one has studied this yet, and so this is one of the other areas of research that we want to look at.